So what I've tried to do is to think about the brief of talking to people who specialise in treating, I think, a lot of musculoskeletal pain, as I've understood the brief. And so I've tried to look at it from two different angles. Urological things that present oftentimes with back pain, and then perhaps a little bit of things that can happen with back pain that can result in problems with your urinary tract. So there's a few obvious things. So anything that blocks up your kidneys can give you pain. And because of the way your kidneys are innervated, you will tend to feel the pain at different levels, but starting off high up in the flank, possibly going around truly into your back. But it will often have radiation. And the radiation may go all the way down to the labia in a woman or to the testes in a man. And the level of obstruction does bear some relationship to where the level of the blockage is. So if you see somebody who comes and they've only just started to pass a kidney stone into the ureter tube passing down towards the bladder, they will have mostly back pain. They will feel quite viscerally unwell, you know, like they're going to die. So they'll tell you the pain is terrible. And as the stone migrates further down the ureter, they will have other different symptoms. So then they will tend to have more sort of labial or scrotal pain, and they will often have urinary frequency as the stone passes down towards the bladder. Testicular pathology, testicular tumours, particularly malignant testicular tumours, can cause back pain either because they have testicular pain radiated to the back, or also sometimes because they've got lymph node disease if they've got an advanced testicular tumour. And testicular torsion seen in teenage men where the testicle twists and loses its blood supply can present with pain. Prostatitis is a quite ill-defined bunch of conditions, and we'll perhaps talk a little bit about that, but certainly that can be associated with back pain. And prostate cancer problems, particularly as the common site of metastasis is to the bone of the spine, although not in any way uniquely there, definitely can present in that way. And then we can see urological complications of musculoskeletal injuries or conditions of the spine. So, particularly with spinal cord injuries, we would expect to see bladder dysfunction, erectile dysfunction, and these are also signs and symptoms of neurological disease, which may be the first presentations of people who come to see you for an opinion. So I want to spend a bit of time talking about things like that. So back pain is one of my bugbear things that I hate as a diagnosis, because we don't ever say that people, dear doctor, please could you see this patient with front pain? You know, you would be laughed out of the GP surgery, but somehow it's okay for us to diagnose patients with back pain. And I'm sure this is just to remind me that I'm preaching to the converted, because I'm sure that the therapy that you might want to treat people with back pain will be hugely dependent on their presenting symptoms and taking a history to tell you what the cause is. But you know, all of these conditions are subtly different in terms of the way that they would present. And the pain history is absolutely classic. Are we talking about midline back pains? Are we really talking about flank pain that radiates around the front and down to the groin, which more often would be associated with renal, kidney or ureteric obstruction, or likewise testicle going up towards the back can sometimes do that. Irritatingly, loin pain is sort of like dermatomal pain, isn't it? So it can be quite difficult to differentiate between an impingement pain, which is radiating round according to the dermatomes, and something that's a visceral pain coming from one of the internal organs. And sometimes we just have to do the tests to find out. So I was going to break the pains up that I see in the clinic and talk to you about how we're diagnosed. So this is a ureteric stone, and you can see that in comparison to this kidney, you can't see any of the collecting system, any of the guttering that takes urine out and down into the bladder is invisible on the scan. On this side, you can see there's a fullness of the left kidney, and the ureter's somewhat visible until you get quite low down. So this is a patient with sort of fairly acute ureteric obstruction due to kidney stone. It's quite a simple thing to test for. There's quite a lot of, they say 50% of all of medicine is wrong, we just don't know which 50% is wrong. And every few years we find out another 50% that we've got wrong. And certainly, there's lots of things that people tell you about kidney stones that aren't true. So people tell you if you're not passing blood, you can't have a kidney stone. So about half the patients won't pass any blood, visible or invisible, with kidney stone. They might tell you that if you drink plenty of water, you'll pass with kidney stone. Well, that's not true, because once the stone is stuck in the ureter and there's hydronephrosis, renal blood flow stops in this kidney and it's all going through the other kidney. So all you're going to do in a patient who's usually quite nauseous if they've got a kidney stone and feeling unwell is to make them feel even sicker and probably vomit. So there's really no point. Once you've passed a kidney stone and are a kidney stone survivor, it's then important that you remain well hydrated for the rest of your life, and because you can't make crystals in your urine if you're not dehydrated. But at the point at which you've got kidney stone pain, there is no point whatsoever in telling them to drink plenty. So those are sort of ureteric colic presentations, but clearly anything that blocks the ureter can cause this. So in fact, if I saw somebody with a really strong history of visible hematuria, particularly an older patient or somebody who's a smoker, I'd be more worried that they'd have a cancer of the lining of the ureter, a urethral or TCC. And we do see those, they're not desperately common, although the more you look for them, the more you find them. And I probably take 10 of those out a year, and there's a fair bit. Sometimes kidney tumours can present in a similar sort of way, although kidney tumours are usually pretty silent. Testicular tumours are fairly common. 1 in 500 men will have a testicular tumour. There's some obvious risk factors. Anyone with a history of maldescent, you may, when you examine them, see these little scars that we use for patients who are born with an undescended testis to have them taken down into a more normal position. Those patients have got about a 1 in 100 risk of having a testicular tumour in their life. But still a relatively uncommon diagnosis. Most men, I think, would go and seek medical help if they had a palpable testis lump. But sometimes it will be the sort of thing that they come to see you something else and it'll come up in conversation. Usually, if there's a concern, it's a fairly simple thing to rule out. Screen men for testicular tumours just is a scrotal ultrasound. It's in and out, they usually be able to get the results the same day. They don't need any more complicated tests. We do other things like markers and CTs and surgery for men who've got a testicular tumour, but just to screen them is a quick clinic visit and an ultrasound. It's a pretty easy thing to do. But these things are all lumps of the body testis. They're not lumps of the collecting system, the epididymis, so the cord structures, the epididymis, where the sperms are maturing before they pass down the vas deferens and out. These are solid tumours of the meat of the testis. And they can metastasise into these lymph nodes on the aorta, and those patients do sometimes present with back pain. Probably a more difficult problem is all the mimics that we have for back pain in older patients, and because I'm a urologist, I'm talking perhaps more commonly about older men. And the question about whether people have got prostate cancer is a bit of a vexed one. And we've probably all, so I'd certainly put my hand up and say I've definitely seen people treated by all sorts of things for polymyalgia rheumatica, lots of other complaints, who have eventually presented with, and the diagnosis is advanced prostate cancer. I'd be interested to see a show of hands for anyone who's seen that sort of a diagnosis in the room. It's not something you've encountered. Well, I worked in Bristol when I was a trainee for a few years, and they had no screening for prostate cancer there at all at the time, and 50% of men presented with metastatic disease, so all the prostate cancers presented very advanced. It's quite a different sort of scenario around here, because quite a lot of men will have PSA blood test screening to tell whether they've got prostate cancer. There is no national programme for that. It's delivered on an ad hoc basis, so if men who are between the ages of 50 and 70 present themselves to the GP and say, I would like to have a PSA test, their GP will give them appropriate counselling about what the risks and benefits of that test are, and then test them. And they'll they may come out with a variety of different answers. They may have a test that says You don't need any tests for prostate cancer. You're completely fine. Your PSA is less than 3. You might have an abnormal number of a PSA more than 3, but not one that's really consistent with advanced disease. Or they might have a PSA of greater than 20. And it's the advanced group that is really relevant to back pain. So we would not expect these lower, usually speaking, it's not quite straightforward, but we would not be expecting these low PSA groups. And certainly these people who've been dragging on with difficult to diagnose systemic malaise, pain, often multifocal pain, and they will often have quite a lot of the red flags that you're, I'm sure, using in your screening of people to determine whether there's something serious underlying these people's pains. But this is what we see in some men. Each one of these black spots is a metastases, and it's not uncommon. I see several of those in every month MDT of people presenting with very advanced disease. It is not a thing of the past. And there's been a bit of a toing and froing about the idea of whether men should have PSA screening in the perhaps 90s and early noughties. Almost everyone was having it, and then there was a lot of stuff about maybe we were diagnosing too many people with prostate cancer, some of whom didn't need to be treated, and that's probably true also. And so then, the message was, don't be tested, which is probably again an oversimplification. And so we're now seeing more metastatic disease again, and there's a sort of, ebb and flow of these things, because the tests that we've got at the moment aren't completely perfect, but they are a lot better than they were. And I think if one was talking about men presenting, men or indeed women, the red flag things of, cauda equina, leg weakness, urinary leakage, loss of bowel control, these are called cauda equina when you compress the cauda equina of your spine, all signs of cord compression, and they're hugely important to get to immediately. These patients obviously have got to go immediately to A&E. Patients with signs of immunosuppression, not just I get a few colds, but they are getting febrile, properly unwell illnesses requiring antibiotic treatment on a frequent basis. People, because you think about discitis and those sorts of things, people with a trauma history, people with a history of cancer that could present with a metastatic burden in the spine, I suppose that's relevant. Nocturnal pain, systemic upset, these things, weight loss, fevers and night sweats because it's a sign of advanced cancer, not just prostate cancer, obviously it's also relevant to myeloma and lots of other cancers, but that's why it makes us worried. And weight loss and fevers, not only metastatic cancer, but also potentially in patients who have infected diagnosis. So you can get back pain, obviously, in people who've got, for instance, a chronically infected kidney. So we see a few of those every year as well. So, syndromic pain. So chronic pelvic pain syndrome is not unique to men, and it's not unique to urology. But when it happens in association with ejaculatory symptoms or urinary symptoms, it is sometimes referred to as chronic prostatitis. And this is a difficult diagnosis because there are lots of types of chronic prostatitis. So acute bacterial prostatitis is people who come to hospital septic and flat on the back with a fever and a temperature, and these are not usually what we're talking about. Chronic bacterial prostatitis are people who come to see me with recurrent urinary tract infections, and they've always got a positive urine culture. We're not really talking about that either. And we're not talking about people who've had chips of their prostate taken out in an operation, which says they've got an infection even though they say they've got no trouble at all. We are predominantly talking about people, these chronic pelvic pain syndromes are the really common thing. And they can have some inflammatory cells and they can have some non-inflammatory cells, but which means that they've got either no abnormality of the urine at all, or they've got some inflammatory cells, so white cells in the urine but no bacteria. White cells in the urine but no bacteria is inflammatory, and no white cells, no bacteria is non-inflammatory. So chronic pelvic, this is probably just pain. It just so happens that the complex of their symptoms includes some urinary symptoms or some erectile or ejaculatory symptoms. And what causes that is poorly understood. It certainly seems to respond to some of the sorts of drugs that are commonly used for back pain. So things like amitriptyline is sometimes used because amitriptyline has a side effect of slowing down your urinary symptoms, so it makes you less likely to have urgency and frequency. It's very good for pain, and it improves sleep quality. But it does have some downsides. In fact, it can make people feel quite sedated in the morning, and some patients just won't take it. But it is quite helpful for this group. But effectively, chronic prostatitis is sort of chronic pelvic pain with some urinary symptoms for which no other useful diagnosis can be found. And therefore, we've started to call it more chronic pelvic pain syndrome. And sometimes, obviously, female patients also suffer with that. But we don't call it prostatitis in them. So just to explain a little bit, in case you're talking to men who've got a prostate cancer diagnosis, because it's really, really, really common. So if you test people for PSA who are between the ages of 50 and 70, about 30% of men will have an abnormal test. About 10% would become symptomatic. 10% of men in the general population would come to the doctor with symptomatic prostate cancer in their life. In other words, they might have pain, or they might have urinary symptoms, or something like that. But they would not ultimately die of prostate cancer. 3%, or a third of those men that present symptomatically, would die of prostate cancer in their lifetime. So it is the most common male malignancy and the most common male cause of cancer death. Okay, so it is an important problem. But the reason why it doesn't figure higher up the priorities is that the majority of people who die of prostate cancer die of it at quite an advanced age. Not everyone, there are people who die of prostate cancer in their 40s and 50s, but the majority of men who die of prostate cancer will be dying in their 70s and 80s. And so if you are a government and you are trying to stop many years of life being lost for people, although this is the most common cause of prostate cancer death, it may not be the maximum number of years lost. So for that reason, it's perhaps been deprioritised slightly. It's pretty simple to screen for it. So if you've got a normal rectal examination and a normal PSA, you're very unlikely to have prostate cancer. However, lots of people who have an abnormal DRE or an abnormal PSA blood test would not turn out to have prostate cancer, and that is the problem. So it used to be the case that if you had these one or other of these things wrong, you had a transrectal ultrasound scans and prostate biopsies. And when that occurred, you had a 4% risk of being admitted to hospital with sepsis, and you had a risk of bleeding and blah, 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 lots of adverse things. What we found is that by using MRI, the majority of the times you can grade people into, so about 20 or 30% of those people actually never needed a biopsy because you can MRI them and by using an MRI to determine how likely they are to suffer prostate cancer, you just don't need to biopsy them at all. And if you do an MRI and it identifies a target, you can selectively target that area, and you no longer necessarily need to do it via a transrectal biopsy, because you can do a biopsy that doesn't go through the, if anyone told you, right, I'm going to do this biopsy, what we're going to do before we biopsy you is we're going to dip the needle in poo and then we're going to biopsy you. You'd say, that doesn't sound like a brilliant idea. I'd say, well, what about if we give you some antibiotics? Probably still wouldn't be really all that keen. But somehow, for years and years, we did that to men without really thinking about it, because it was the only way that we had to diagnose prostate cancer. We thought it was probably better to diagnose the prostate cancer than not. But it in fact transpires that doing transrectal biopsies unguided with no MR, it's probably about as dangerous as just not worrying about whether they had prostate cancer or not in the first place. But using these more novel techniques of MRI and a guided biopsy, things have changed, and now that would definitely be considered to be a beneficial intervention for people who've got an abnormal PSA. So that's just to indicate the different ways of doing it. This is how we used to do it, and this is now how we do it. So we still either anaesthetise them and put a probe in the back passage, or you can actually do that, believe it or not, with a local anaesthetic without men punching you in the head. And some of them even say thank you afterwards, but that's probably give them a little. And so this is the sort of diffusion weighting imaging we see. We see these sort of little lesions in the prostate, and we can selectively target those with needle dive. And so I guess if you were, so there's going to be tons of men out there who've either got an abnormal PSA or prostate cancer, and lots of them are going to come and see you because they've got musculoskeletal pain. And I'm not saying in any way at all that you need to be really careful with most of them, because most of them have got musculoskeletal pain. It's nothing to do with the prostate cancer. But to have some appreciation about what the risk of prostate cancer in the future. So if they've been treated for prostate cancer with surgery or radiotherapy and they've got an undetectable PSA, they have not, by absolutely they haven't got metastatic disease. They cannot have metastatic disease. Anyone with a PSA of less than 20, pretty unlikely to have metastatic disease. Very, very rare indeed. And people who are effectively treated with hormonal therapy, in other words, people who had metastatic disease but have responded to treatment, are also quite unlikely to present with current symptoms, with the caveat being that they are on some sort of surveillance program and having their blood tested regularly. Newly presenting men who've got a new diagnosis of high-risk prostate cancer definitely could have metastatic disease, and particularly the high-risk population is men who are on hormonal therapy and they're saying to you things like, and the doctor's changing my prescription because the first-line hormonal treatment hasn't worked, or and I'm having chemotherapy for it. These are the sorts of men who are very likely to have back pain that is related to their prostate cancer. You can see you get complete replacement, wedge fracturing, and spinal cord compression. These are things. And this is to identify. So this guy is John Gleason, who invented a grading score for prostate cancer, and some people describe it in, put the analogy of all prostate cancers are cats, but some are pussycats and some are tigers. It's not quite as simple as that, but it is definitely true. You can see 15 years after diagnosis, he's got the lowest grades of prostate cancer in his original work. 70% of people are dead, 70% of people were alive, and almost all the other people died not of prostate cancer. Whereas if you've got high-grade disease, then almost all died of prostate cancer. So what's happened in the intervening years between about 1970 and the current time is that we've got really, really very good indeed at telling whether people have got this or whether they've got that. Okay? It used to be the case that you just stuck 6 needles in the prostate and it's a bit of a lottery what you hit. But now with MRI targeted biopsies, we're really pretty good at that. And so treatments for prostate cancer can focus on localized disease, locally advanced disease, where it's gone through the capsule of the prostate and started to invade the other things, or these presentations. And these are definitely the group of patients who we're concerned about them presenting with back pain symptoms. So that's the first bit that I was going to talk about, which was some things that are for pain. I thought I might stop there just for a minute, and if there's questions about that, we might deal with that once I've got those things in our minds. But if not, I've got some slides on talking about how spinal pathology can present in the urinary tract.
You mentioned about you can't get kidney stones if you drink enough water, if you're well hydrated. Is that categorical? I mean, some people do produce kidney stones more often than others.
Yeah. So technically, it is probably true that if you could get enough volume into people, then even people with, so the people who've got the highest risk are people with genetic conditions like homocystinuria, and those patients are at very, very high risk of producing stones, to the extent that we tell them to get up in the middle of the night. The old advice used to be set your alarm clock, have a pint of water in the middle of the night, which works very well when you're 20 and your bladder capacity is 600 mils. But when you're 60 or 70 and your bladder capacity may be 200 mils, it's quite difficult to do. People have to work. Their life isn't just drinking water, but it is technically, from a chemical point of view, you form stones because your urine is supersaturated. And everyone will have different points of supersaturation. So there are things that are inhibitors of stone formation, like citrate in your diet, and you can change the pH of people's urine in order to stop them forming stones, and we often give people artificial citrate to stop them forming stones. So everyone will have a solubility point at which they will crystallise. I don't know if you ever did crystal gardens as a kid, but all the things we dissolve in warm solutions, because you can get more in when it's warm, and then as it cools it crystallises out because the solubility product changes as the solution cools. And it's the same in people. What you're eating and drinking is how much crystal you've dissolved in the solution. But if you put enough water in it, it will be soluble. And so it is more or less true that you can treat everyone. So 5 simple rules for preventing stone disease in people who are prone to it, which is true for almost all of them, are, it's a bit like they said one of the people in the driving part of in fact, in the Telegraph, he was asked by the driving correspondent what was his top 5 tips for saving money, and the financial correspondent, and he said all 5 tips were never buy a new car, which may have been true in those days, but I don't know now. But the top 5 tips for anyone with stone disease are all drink more water than you're drinking now. But if you want 4 others, don't add salt to your diet, be more vegetarian or eat less than a big banger of protein a day. Continue to have dairy in your diet, because dairy exclusion means that you're more prone to getting kidney stones. And the oxalate containing things are also ran with it. So people used to worry about chocolate and strawberries and all this stuff. It's a bit of an old wives' tale, really. Dilution, salt avoidance, avoid excessive animal protein, have your 5 a day, fruit and veg, and don't sweat the small stuff.
With the water hydration, is it also that you're just literally pumping water through your kidney in the sense, well, not pumping it, but it's passing through, and therefore if you've got a small amount of stone formation, it's more likely to clear, or is that just completely not the way?
No, it's so that's why it doesn't work to dilute as a way of getting rid of stones that have already formed. You cannot remove stones that are already there by hydration. It's just that once you have got them stone free, you can prevent new stones forming if you dilute the urine. So the only way to get rid of stones, that there are regimes for non-surgical treatment of existing stones, but they are things like adding citrate to the diet, and potentially controlling gout if that's an issue with allopurinol. But basically, once you've got a stone, you're going to have to break it up somehow or pass it out, or both.
In the ideal world, how frequently would you do PSA tests as a preventative?
Yeah, you would, in an ideal world, you would screen people at 50 or 5 years younger than their nearest affected relative if they had a family history of prostate cancer, presenting at a young age. And then once you had screened them, you'd know their PSA. If their PSA is less than 1 and they're older than 60 years old, they never need to be screened again. So if we'd known that before the studies started, we would have made studies that were twice as effective, because it transpires that the halfway point for PSA is 1 at 60. So basically, if your PSA, if you have an initial screening PSA and your PSA is less than 1 at 50, you probably don't need one for at least 5 years. If you have a PSA that's between 1 and 3, you should have it every year or 2. And if you had a PSA above 3, you should be investigated.
Prostatitis, does that give a range PSA as well?
It does. So that's difficult. So if you've had a history of urinary infection, if you've had operations on your urinary tract, or if you've had prostatitis, which is just another urinary infection really, then you will have transient rise in your PSA. And so I suppose one of the ways that you might, it's a bit of a double-edged sword. So if prostatitis is a real cause of pelvic pain, you should have transient rise in your PSA, and some of those men do. Oftentimes we end up not doing it because it's better to sort them out if we're going to treat them with antibiotics, and then wait and do a PSA later so that they don't get artificially worried about prostate cancer. Because oftentimes, once you've opened the Pandora's box, they're then down the track of having an MRI and biopsies and investigations that you don't necessarily want them to do because you've examined them and you're fairly sure the prostate feels normal, or you've got an old PSA that said, well, 6 months ago the PSA was 0.9 or something, so you think, well, they're probably at low risk. So if you've got those clues, you can often defer, but for people coming with their first diagnosis of prostatitis, they may well get all the prostate cancer investigations first, and then a diagnosis of prostatitis. Particularly if they've got palpably abnormal prostate, which is quite common in people who've got benign enlargement and maybe infection and so on. Okay, so should we just chat a little bit about spinal pathology? So this is my understanding and sort of mental diagram about how the urinary tract works. So here is a bladder. Here are the sensory nerves going into the spinal cord, where there's this thing called onus nucleus. And then when you're a toddler, or when you're pre-potty training, your bladder fills up, stretch receptors make these nerves fire, hits onus nucleus, goes to the pudendal nerve, relaxes the pudendal nerve so that the striated sphincter relaxes, and you have a reflexive contraction of your bladder, and your sphincter relaxes, and you wee into your nappy, and that's how little babies do it. When you get to be potty trained, you are having these signals that go up to your pontine micturition centre in the brain stem, and that's as you become potty trained. That is how you become. This is already wired up, but it becomes more active, and then that stimulates down to your bladder to make it contract. And then as you become potty trained, these areas in the higher brain, the periaqueductal brain, basal ganglia, and the frontal lobe, are all able to inhibit either excitatory or inhibitory signals to that area of the base of the brain in the pons. And therefore, by say your frontal area, being able to inhibit it, you can defer micturition. So I might have had my 2 glasses of water having come in from a day's operating, be desperate to have a pee, and I could still stand and do another 10 minutes of my presentation. As you get older, neurological diseases, and obviously you may be seeing people who present with neurological diseases, they come with a bit of tremor or unsteadiness, or they're wanting a consult about that. If they're having little strokes or they've got other disease that happens inside your brain, they may lose this inhibitory control, and therefore they may find that they've got new urgency or frequency because their higher centres are no longer able to inhibit. And we definitely see that in people who've got Parkinson's as well. Their basal ganglia have deteriorated, and therefore the inhibitory signals are weaker. Men or women with Parkinson's, but predominantly men, will often present with urgency and frequency. And there's a particularly nasty form of Parkinson's called multisystem atrophy, which presents with very early erectile dysfunction, and then urgency frequency, which is MSA type C, is very progressive and nasty. But I think it does sort of illustrate that there's been lots of work doing these sorts of MRs and then functional MRs that have allowed us to MR people when they're getting to drink, and then see when they're getting urgency, and then you can see which of these centres in the brain. So this is the periaqueductal grey matter and the pontine micturition centre, and there are connections between that. When your frontal cortex says, I'm getting a signal from my pontine micturition centre, the bladder's full, it's the right time and place, and now finished my talk, it's time to go. And then your pontine micturition centre will fire off and stimulate bladder contraction and inhibition of your pudendal nerve, so that you're able to have a pee. Clearly, a simple system that told you about what sort of things you might expect to be associated with spinal cord or brain injuries will be quite useful. And so aimed that you could make this really, really complicated, and I'm not specifically a urologist. In other words, somebody who only deals with urological diseases. I do, benign enlargement of prostate cancer, taking 2 renal tumours out today. So I'm doing a much broader bit of work than that. And they would, if you look at the people who work in the spinal cord injury units, like Stoke Mandeville or the one near Leeds, they absolutely are obsessed about what level the injury is and exactly what nerves might be impinged. But actually, in practical terms, unless somebody's taken a chisel to your spine and you've got an absolutely clean lesion, it's very uncommon to have a complete spinal cord lesion. And most of these patients, as I'm sure you see, have got a muddy, mixed picture that doesn't exactly fit with the neurology you get in all the books. So the simple thing is, do they have a suprapontine problem? Is there a problem with their head above the pontine micturition centre? So these are strokes, strokes, brain tumours, these sorts of things. Dementia is certainly, dementia is brain failure of undetermined cause. Some of them are known, some of them are not. Or Parkinsonianism. These are all suprapontine things. So generally, people present with frequency with them because they've got loss of their ability to inhibit the need to go and pass urine. So the next group is the subpontine suprasacral group. So, funnily enough, although these all affect nerves in the same region, because of the different pathologies, they are associated with very different sorts of prognoses. So spinal cord injuries are very dangerous. So what's the most common cause of death in people who have spinal cord injury historically? Any shouts? Kidney failure. Okay. So kidney failure. So when you have a spinal cord injury, you cannot coordinate your bladder contraction and your urethral sphincter opening, and you get this thing called detrusor sphincter dyssynergia. So your bladder contracts, your urethral sphincter is tight shut, and you get reflux of urine back up into your kidneys, which effectively causes renal failure and destroys your kidneys. And so pretty much until about 1940, everyone who had a spinal cord injury would die within a year or two of renal failure, stones, infection, these sorts of things. So it's a really serious thing. So now, all truly spinal cord injured patients who are paraplegic or tetraplegic because it's affected their hands, the paraplegic people will be doing intermittent self-catheterization to empty their bladder, and they'll either be on Botox or drugs or have had surgery that will stop the bladder contraction. So they will passively empty their bladder with a catheter. And patients who are tetraplegic won't obviously do that because they don't have any hand function, so they can't themselves catheterize their bladder because they've got high lesion. If you're tetraplegic, you will generally have either somebody else will do it for you, a carer will do it for you, or they'll have an indwelling catheter, or they'll have something like an ileal conduit that will a stoma for urine on your tummy. So this is a really important thing, they're not usually ambulant. They're usually identifiable because they are non-ambulant patients. So they're coming in crutches or in a wheelchair, but important group. But MS patients will often have involvement of their urinary tract, but they will often present initially with subtle signs. But they're quite a safe group because they don't have a complete transection of their spinal cord. They don't tend to get that. They tend to get a bit of urinary retention where they don't completely empty their bladder or frequency. They don't tend to get this terrible detrusor sphincter dyssynergia problems. And then the subsacral patients, cauda equina or a nerve injury in the pelvis, these patients generally present with urinary retention. They have high capacity bladder with overflow, and the thing that you can tell pretty much if an adult who is past the age of, past the age of 12, tells you they've been completely continent and then they've started getting incontinent, but they're only incontinent ever at night. Okay, that is pathognomic of subsacral. So it can't be pathognomic means it cannot be any other diagnosis. The only diagnosis to consider is urinary retention with overflow. So So it's a nice screening question, because if you see somebody and go, and they say, oh, it's really funny, this just started wetting the bed, I can't work out what it is, then you know, if you've got a hand on their tummy, you'll feel that they've got a very big palpable bladder, and it can really be the wrong diagnosis. So obviously, I'm running out of time, probably, but obviously we see all sorts of things with these sorts of groups of patients: urinary retention, flow problems, catheter problems, incontinence, erectile dysfunction is very common in spinal cord injury patients and neurological disease, and we can fix or help most of it. And kidney stones and urinary tract infections are overrepresented because they get a different type of stones to the ones that we were talking about just then. They get what we call infection stones. So if you've got chronic urinary infection, the pH of your urine changes and you'll get infection stones. And that's a different pathology and requires different treatment around antibiotics and so on. I think I'm going to stop there because I think in danger of overrunning my time. But if you've got any questions, I'm happy to help.